My name is Beth McIntyre. I'm a 67-year-old chef and I was recently diagnosed with Alzheimer's. This is my story.
Grandma, what's for dinner?
I was thinking lasagna.
That sounds great.
Hello? Oh, how are you? Oh, my day has been fantastic. Are we still playing bridge tonight? I'm looking forward to it. Alright, I've gotta go. I'm making dinner. What's going on? What's going on, me? What are you doing?
Grandma, you forgot your lasagna! Grandma, go sit down. Go sit down, Grandma. It's okay, I got it. Go sit down.
Where did my phone go? I had it like a few minutes ago. I thought I did. Did you take my phone? Is it in your bag?
No.
I don't like these kind of jokes. I know these kids these
Grandma,
days.
I don't have your phone.
I know you have it. Just
I
give me
don't
my
have your phone.
back.
Grandma! Hey, Grandma, why is your phone
Did you
ringing?
take my phone? I knew you took it.
Oh my God, no way.
Can I help you?
Here, Sonny, I'll iron for you.
You have a new notice it?
Okay. No.
Grandma, there you are!
Where am I?
I am so sorry, everybody. Grandma, you missed it.
Miss what?
We're going to the grocery store.
Hello? Where am I? Oh no, I'm lost. Oh no.
Grandma, I'm here.
Oh no. Oh no.
Come on, let's go, Grandma. Come in.
Hi, I'm Dr. Grace. You must be Mrs. McIntyre.
Yes, ma'am. I'm Sarah McIntyre.
Nice to meet you.
Nice to meet you too.
So I'm just going to ask you a couple questions, how to get an idea of what's going on here. What's your first name?
It's Beth McIntyre.
Beth, okay. Nice name. And what's your date of birth?
April 12th, 1957.
Okay. And what brings you in today?
We've been having some memory problems, losing things, forgetting things,
Okay.
thinking things are off.
Okay. We can go more in depth with that in a little bit. Do you have any allergies?
No, ma'am.
Okay. Now I'm just going to ask you about your medical history. Do you have any history of heart disease in your family?
No.
No heart disease. How about seizures?
No.
No. Migraine headaches?
Migraines and headaches, but she's medicated.
Okay, good. Stroke?
Yes, her brother died of a stroke at 63.
63, okay. Kidney disease or thyroid disease?
No, none of that.
None of that? Okay. Alzheimer's, dementia?
Yes, we do have that in our family. She had it on her father's side.
Tobacco use? Do you smoke?
Oh, ma'am.
No? Okay. How about alcohol use?
No.
No. Okay. I'm a little bit concerned just about some of the things you mentioned with the stroke and Alzheimer's dementia. I think that we should probably further investigate that. I think we should get some other tests, maybe a blood test. There are a couple other tests we can also examine too. The essentials of an Alzheimer's diagnostic workup include medical history, clinical exam, neurological testing, lab test, and brain imaging. During a physical exams, doctors will conduct an eye examination and acuity test using an ophthalmoscope, an ear, nose, and throat examination using an otoscope, thyroid examination, and reflex test to rule out other causes of symptoms. The neurological testing portion often utilizes MMSEs, which are many mental state examinations. They are 30-question surveys used to measure cognitive capacities. During the test, patients may be prompted to spell a word backwards, repeat back a phrase, display orientation to place or time, as well as draw geometric figures. Scores between 20 and 40 are associated with mild cases, 13 to 20 indicate moderate cases, and 0 to 12 is considered severe. An example of a question that may be asked is to draw a clock and present all of the numbers in the order that they are supposed to be. Urinalysis is used to rule out liver dysfunction as the cause of exhibited symptoms, particularly pertaining to mental confusion. Blood samples can be tested to determine blood count to rule out anemia. Anemia is characterized by the lack of blood cells available to deliver oxygen to various tissues, including the brain. Such impairments could cause similar neurological deficits present in Alzheimer's patients. There are currently no validated biomarkers for Alzheimer's disease. However, recent studies indicate cerebrospinal fluid biomarkers, beta amyloid and tau, as potential risk factors. Accumulation of beta amyloid is due to the overproduction or failed clearance mechanisms. Excess beta amyloid forms plaques, blocking proteasome function and inhibiting mitochondrial activity. It also causes hyperphosphorylation of protein tau, which becomes entangled and acts as a synaptotoxin. The dysfunction of beta amyloid and tau interfere with neuronal ability, ultimately leading to widespread apoptosis. During genetic testing, a blood sample is analyzed and tested for mutations to the PSEN1 gene, which encodes for presenilin 1. Presenilin 1 is responsible for the conversion of amyloid precursor protein APP into beta amyloid.
PS1 mutations on gene G206A are responsible for the more aggressive forms of Alzheimer's disease. However, there is a less common mutation known as the P2 gene mutation, which also attribute to aggressive forms. Both are pathologic mutations which lead to the overproduction of high amyloid beta peptides, which further support the concept that changes in APP processing are central to Alzheimer's disease pathology.
Alzheimer's disease is believed to be strongly associated with atrophy of the lateral entorhinal cortex and the hippocampal regions of the brain. Both structures play an essential role in memory formation and consolidation. Magnetic resonance imaging and computerized tomography have been used to rule out causes of similar symptoms like tumors, strokes, TBI, or fluid accumulation. Shrinkage of the hippocampus has been found in a large quantity of ALZ patients. Positron emissions tomography uses radioactive tracers which bind to beta amyloid proteins in the brain. I would like to diagnose your grandmother with Alzheimer's based off of the symptoms you all have described, and on her functional MRI and her CT scans, we saw some areas of decreased activity and just regions where you could see there was a decreased function, as well as in her blood test, they were showing buildups of this, it's called amyloid beta protein, that is commonly associated with Alzheimer's. So that's what gives me the reason to believe that. We can do further analysis, but I really, really feel confident that this is what's going on.
Okay.
Do you have any questions for me?
Could you be there when I talk to her? Are you gonna help me talk?
Yeah, of course.
A child whose biological mother or father carries a genetic mutation for early onset FAD has a 50-50 chance of inheriting that mutation. If the mutation is in fact inherited, the child has a very strong probability of developing early onset FAD. Early onset FAD is caused by any one of a number of different single gene mutations on chromosome 21, 14, and 1. Each of these mutations is caused by abnormal proteins to be formed. Mutations on chromosome 21 cause the formation of abnormal amyloid precursor protein, APP. A mutation on chromosome 14 causes abnormal presenilin 1 to be made, and a mutation on chromosome 1 leads to abnormal presenilin 2. Each of these mutations plays a role in the breakdown of APP, a protein whose precise function is not understood yet. This breakdown is part of a process that generates harmful forms of amyloid plaques. The causes of late-onset Alzheimer's are not yet completely understood, but they likely include a combination of genetic, environmental, and lifestyle factors that affect a person's risk for developing this disease. However, one genetic risk factor, having one form of APOE gene on chromosome 19, does increase a person's risk. APOE, E2, E3, and E4 all increase risk for Alzheimer's disease.
Chronic sleep deprivation in mouse models of Alzheimer's disease were shown to make brain plaques appear earlier and more often. It was also found that the sleep-regulating protein orexin appears to be directly involved in the increase. When orexin was injected into the brains of the mice, they stayed awake longer, and the amyloid beta levels increased. When researchers used the drug almorexin to block both orexin receptors, amyloid beta levels were significantly lower. I'm here. Grandma, we're just here to see the doctor. It's okay. What are we doing? We're just going to talk to the doctor. We'll go home soon, I promise. Come in. Hi, how are you, doctor? Good. How are you, doctor?
Hey, how are you doing, Miss? Yeah? Alright. You know why you're here? No. You don't know? Okay, that's okay. I would like to diagnose you with the Alzheimer's disease, and I also like to start you on a low dose of Aricept. It's a cognition-enhancing drug. It is basically just going to help kind of manage the symptoms. I do think that she needs to have a caregiver, 24/7, no driving. I do recommend that you get out at least 20 minutes a day. Just go for a walk around the block with someone. Other than that, just we can talk about some alternative treatment. If you're interested, I can give you some references to some clinical trials as well that may be going on. There is not currently a cure for Alzheimer's. There is no way that we can treat it, but we can definitely manage it.
Okay.
In addition to APOE and APOJ genes, TREM2 mutations are being shown in research to derail immune cells' plaque-clearing activity. Mouse models and TREM2 gene studies are being shown to have microglia which can efficiently surround amyloid plaque deposits. LDL and APOJ increase efficacy of microglia to surround amyloid beta aggregates by the lipoproteins forming complexes with amyloid beta aggregates. Uptake of the lipid protein amyloid beta complexes were shown to be microglia dependent on TREM2 functions.
Inhibition of neocortical beta amyloid accumulation may be essential in an effective therapeutic intervention for Alzheimer's disease. Copper and zinc are enriched in beta amyloid deposits in Alzheimer's, which are solubilizable by copper and zinc selective chelators in vitro. Furthermore, research in stem cells has been shown to be effective in both intracerebral and intracerebroventricular injections. Both methods showed significant improvement in cognition and memory. Some research suggests potential treatment through the use of drug therapies that harness beta amyloid antibodies to modulate gamma and beta secretase. Research using tau protein is yielding potential serotonergic antagonist vaccines to act upon tau protein AADVAC1 and ACL35 as early-stage preventative measures.